mentioned bone density
Yeah.
and bone density
Yeah.
health a lot.
Yeah.
Musculoskeletal syndrome of menopause,
Yeah.
to me, speaks to bone density. In my little bit of research about this, that greatly declines for women over time, and that decline seems directly linked to, like you said, a decline in estrogen.
Yeah.
And those two things are completely connected. How do you address that, or
Yeah.
how are you addressing that with your patients, with the public, with your
Mm-hmm.
books, for women in their 20s
Yes.
and in their 30s, so that they're not coming into your office at 40 asking these questions? They're coming in saying, like, what else? What more can I do? I guess, how are you getting in front of that and being a little bit more proactive and preventative about it?
Well, I love that you're giving me the opportunity to talk about bone health across the lifespan, because what happens is we don't think about our bones until they fracture, because we think of them as the strong, silent type, hanging out, giving support to muscles, which frankly would, without bones, be a quivering mass of tissue, right? If they would be just laying there. But with the support of the bones and the tendons that connect them, that's how we locomote. But bones, in fact, are master communicators. They are storehouses of our minerals, which we need. They are producers of our blood cells. So they're not just strong, silent types. They, from the top of our head to the bottom of our toes. Well, the fact of the matter is that I see a lot of 24-year-olds today coming in with bad bone density or fracturing. And I think that can be for a lot of reasons. But number one, women are still living under the lie as we grow up that we have to be as big as our pinky. We have to be teeny tiny. We can't gain weight. Listen, when you do that, many times women will not have a period for 6 to 9 months, and you are therefore not laying down bone. So that's number one. It's a nutritional problem. Number two, we are raising a generation of digitally minded people. We are no longer telling our children to go out and play and don't come home till dinner, partly due to safety, partly due to the digital world we live in, right? Mm-hmm. So we are never pounding our bones and building enough muscle to be healthy. And number three, what about the women that are? We have now had 53 years of Title IX, which is the law that equalized sports for women and men. Well, female athletes are getting better at this, but if they're like the athletes I've cared for my whole career, they're sustained on gummy worms and pretzels and, so they're using a lot of energy. They're not replenishing their energy. They're existing in relative energy deficiency, again, not having periods, not producing estrogen, and not laying down bone. So that's number one. We have to get in front of this for our daughters. We are maximally laying down bone by the time we're 30. We can lay down bone later, but that's our natural maximum. So I call the decade between 35 and 45 the critical decade to get our health stuff together. We need to build muscle. We need to build bone. We have enough estrogen to do it. But what happens when women start having babies? Well, during pregnancy, we have lots of estrogen, right? But what happens when we breastfeed? Well, I encourage women to breastfeed. I breastfed for a year, but we know that within the first 6 months of breastfeeding, we can lose 15% of our bone density because we lose it to feed our babies at a rate of about 400 milligrams a day.
What is the mechanism by which women lose bone density through that?
Because remember, one of the functions of our bone is to be the mineral storehouse of our bodies. And calcium is one of the main minerals stored in our bones. And if we're making milk, what do we tell people to do? Drink milk to get your calcium. We're making milk. We're making milk with high content of whey protein, leucine, right? So that's protein content. And high calcium content. Where are we going to get the calcium? Well, we can eat the calcium. So if mothers keep up and eat the calcium, they can replenish, but our body's going to take it from our bones. To make milk, our body takes calcium from our bones. It's then the mother's body's responsibility to replenish her bones. What if we are so tired and so busy we don't take in enough calcium? What if,
Mm-hmm.
well, that's the main thing. What if we have multiple children in a row? What if we have child, 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 which happens, right? Every couple of years
Mm-hmm.
we breastfeed for a year. Now listen, I don't want anybody listening to this to hear me say, don't breastfeed. That is not what I'm saying. What I'm saying is be aware that you are feeding your child from yourself and that you
Mm-hmm.
must replenish yourself so that by the time I had my last child at 40, by the time I get to 40 and my estrogen is going downhill, I'm not starting at a deficit. Because what happens when we stop making estradiol? Estradiol is critical for controlling a cell that breaks down bone called the osteoclast.
Mm-hmm.
What happens when we lose estrogen is our I always do this. This is the osteoblast. This is the osteoclast. It's sitting along a bone, if you will. Here's a bone, like this.
Mm-hmm.
So when we don't have estrogen to control the osteoclast, we break down bone faster than we build bone. We're still trying to build, but breaking down outpaces it. So if we replenish our estrogen through hormone replacement therapy, we will not lose as much bone. Because why do we care about that? Here are the statistics. 1 in 2 women. 1 in 2. So if you were a woman, I would be saying things like, it's either you or me, girlfriend, you or me, that's going to break a bone due to osteoporosis in our lifetime. Women sustain 70% of all hip fractures. The data on that is devastating. 50% of the time, we will not return to pre-fall function, meaning you can't live in the house you raised your children in or that you worked for your whole life.
Can't walk up the steps.
You cannot.
Can't reach the top cabinet. Yeah.
Yeah. And 30% of the time you die in the first year. So not on my watch. I get very, as you see, passionate about this because in all the raging debate that's going on right now in the world about hormone replacement therapy and the relative risk.
It's controversial.
Well, it shouldn't be.
Right?
It shouldn't be, and I'll tell you why. But there is no doubt of the role of estrogen on bone health. In fact, the FDA approves it for prevention in postmenopausal women. So I tell all the other doctors in my space, I'll take my 50% of people that I'm going to save their lives. I'll take them. You can debate about the heart and the brain, but I'll take my bone people, and in that, I will save them from the ravages of becoming frail. But listen, let me tell you why my view on hormone replacement therapy, since we're sitting in this space this minute. I believe that every person is a sentient being with agency to make their own choice. I believe that. But I demand or urge you to make that choice based on data and not being driven by fear. So what do we know about the Women's Health Initiative study? The study published in 2002 that took hormones away from 2 generations of women. The baby booming women are...
It seemed like it skewed an entire generation of thought.
Oh, and it still skews thought because... So here's what the data showed. First of all, that study, which was the largest funded health study in the history of people, $1 billion, accrued older women. The median age of women accrued to that study, which was really meant to look at heart disease, skewed into their late 60s. The second reason the Women's Health Initiative data, the second reason the Women's Health Initiative data is something that has taken estrogen away from 2 generations of women is because, let's just tell you what the data were. The study was stopped early because the control group was found to have 3 out of 1,000 risk of developing breast cancer. The study group, all older women, was found to have 3.8 per 1,000. So it's less than 1 woman per 1,000 increased rate of breast cancer diagnosis and no increased death. And I am not for 1 minute, none of us are, saying that 1 woman isn't important. But what we're saying is that is not statistically significant. And so even the lead scientist on the WHI has now said that, the data didn't bear it out. And so It's a problem because what happens now here, I'm going to describe to you, let's talk about longevity of women. I'm going to describe to you because I'm a practicing orthopedic surgeon, meaning I still take call. This is the future of women. If we don't step in front of this in the way we've talked about today, with pivoting our mindsets, building a lifestyle, and paying attention to our hormones. When I get called to the emergency room to take care of a woman who has broken her hip, number one, she's laying there in her hospital bed in that terrible crumpled old blue gown we give people that opens up in the back, and she's in terrible pain, number one. Number two, many times, unfortunately, she's incontinent because she has had the gynecourinary syndrome of menopause, which wreaks havoc with our bladder, causing bladder infections, pelvic floor dysfunction. And she was never treated with vaginal estrogen, which is incredibly safe. Number three, her heart is often so bad that the medicine doctors cannot clear her for a 45-minute surgery, which is all it takes us to fix her hip. And finally, she will usually have a touch of dementia, whether it's stress-related or full-on Alzheimer's. And she's laying there in bed, usually with her daughter at the bedside. Her oldest daughter is usually her caretaker. And do you know what she's saying to me? Other than she's in terrible pain, she'll look at me standing there in my white coat as her doctor or her daughter, and she'll say, I was once like you, vibrant in midlife. How did I get here? How did I get to be in this place? And I'll tell you how she got to be there, because we have gotten used to the suffering of women. We have believed a study that took the elixir of longevity away from women, and we view women in society not in the same way we view men. So I think that we have tremendous work to do, and I'm so glad that your group is letting us talk about the longevity of women, because frankly, women live longer already, but they don't have to suffer.
We love this conversation because how do we, what advice are you giving women and patients and your listeners to, I guess, two-part question. One, what advice are you giving to these women who are experiencing this musculoskeletal syndrome, right? Like, how can they tell what those signs are very early on to get in front of that so that they can maintain that vibrancy longer? And then two, what is the, I don't want to say it, is there a past the point of no return moment? Because I feel like there's always you could always take positive steps, but for some of your patients or people who are listening that might be older, in their late 50s or 60s or 70s or whatever that demographic is, how are you helping them to kind of regain that control and empower them to say, hey, it's not too late. You're not going to be, you're not going to be doing the long jump, but you don't have to just take small steps. So I guess, yeah, two-part question there.
You could be doing the long jump if you invested every day in your mobility. You really could. And we have lots of examples in masters athletes doing this right now. But number one, I think that your listeners should know that people have been studying how to improve health span for a long time. And in fact, the first studies were done in 90-year-old men by Maria Fiatorone, 90-year-old men in nursing homes, and through simple exercise programs, started out in a chair, they gained 150% of function back. So there is never an age and skill level when our body will not respond to the positive strategic stress we put on it. It's the giving up. It's the cop-out attitude that I talked about, pivoting our mindset. Because what it does take a daily investment. But back to the question about health span and lifespan, women on average live 6 years longer than men. When we think of health lifespan, on average in the United States, it's 76 point something for men and about 80 for women. But our health span ends at about 64. Data will show that the diseases that kill us rear our ugly heads around 64, so that people spend 3 days a week in the doctor's office in the golden years. That's not very golden to me, right? But the fact of the matter is that when women lose their estrogens, around 50, that's when the real disease starts, because our lipid panel goes up, we gain weight, our metabolism is different. We start losing 20% of our bone density and up to 10 to 15% of our muscle mass. So, yeah. hmm I think everybody, what I mentioned to you before, the critical decade being 40-ish. I think everybody around 40-ish, if they've never had it before, should have their first annual physical with complete blood work, right? Get a body composition. For women, get a DEXA scan, even though insurance won't pay for it. Get it, right? So you know where you are. You can't know where you're going if you don't know where you are. Certainly do it at 50 for both men and women, and get a colonoscopy along the way, right? Um, because without changing anything a woman has ever done, all of those things change because of the loss of estrogen. But we can reverse those things. And, the reason I wear a CGM is out of the quest to know how my body is responding to the food I eat. And when I started wearing it, I was appalled. It was horrific to me that my first fasting blood sugar was 99, because what do we know? And I was healthy as I thought I could get. I wasn't, but right? 99, what does that mean? That means if the normal high for fasting blood sugar is 85, and every point above that you chronically carry adds a 6% chance of developing diabetes in the next 10 years. That means if you're, air quote, been told that you're pre-diabetic with a blood sugar in the high 90s, low hundreds, and your doctor pats you on the back and says, oh, just look at what you're eating, you have a 100% chance, if you don't change something, of getting diabetes in 10 years. So we should not be so lackadaisical about pre-diabetes, because diabetes is a precursor of Alzheimer's disease. So let's jump off the not worrying about our lifestyle bandwagon and know ourselves and get a little lab work and build a plan.
So that does bring me to one of the other questions is, how do we question these biases that seem to exist now? How can women question these things, and men too, and I guess how can everyone kind of question these established, if I Google something and it comes up, that to me is a bias that exists on the internet somewhere, which is everyone's first resource, whether we like it or not. But how do we begin to question that? And I don't want to say question. I don't think we should question doctors. I don't think we should question the medical establishment. I don't. It's like there's. I think because we have so much access to information that it's difficult to know what to question. But how do we begin to kind of look at our own lives and say, okay, I want to take control of this. This is individualized for me. How can I question that, safely and correctly with my doctors and with the medical people that I'm seeing?
I think that the first thing to realize is that most primary care doctors, your doctors, are trying for you not to be dead. So they're disease care doctors, right? They're not trained to be health optimizers. However, yes, I run, in addition to orthopedics, I have a longevity clinic that I have individuals and groups. And so when people come to me, I am not doing disease care for them. I am doing first health optimization. So we would take your, whatever it was, 101, and we would say, how can we, because that's fine, not disease coded yet, but how can we optimize it for you through lifestyle, all the things we've talked about today. Once we have optimized through lifestyle, maybe some supplementation, then we can apply more advanced things like we do for pro athletes to help you live in peak performance with the most energy that you need, right? With the most access to health. And then if we want to, when you're optimized in your health, when you're living in peak performance, then we can get into the really esoteric longevity, rapamycin, all the this and that has rat data associated with it, but so many people want to explore, right? But I think the basis is to move out of disease care into health optimization. So finding people you can trust means that people have to realize that they are the chief medical officer of their lives, right? At this point, clinicians are trying to help you not die of a disease. You have to be the vetter of information. You know what? Google is never going to be enough. Find a few clinicians that you know you can trust, and it may take a little vetting, a little energy expenditure on the individual's part, but you are worth it. If it were your kid, you'd find the best. If it was your car, you'd find the best. For yourself, you deserve it.
Um, my colleague Erin Hunter, she's our editor for the Livelong newsletter. She spoke to Dr. Jennifer Garrison recently, and Dr. Jennifer Garrison, she's a professor. She's a part of the Buck Institute on Aging. She's got great accolades, and she said this one thing that stuck out to me, and I will be paraphrasing it, but she said that the goal is not to delay menopause. And they were in a discussion about women's health, and she said the goal is not to delay that. And I have taken this; it's been floating around my head since I was again sitting in the background of the conversation, just listening, because it was like a light got switched on, where it's like, oh, we're not fixing this. We're working with this, and we're trying to identify. We know that this is inevitable. We know that this is going to happen, and we can combat it with the things like you said, resistance training, working out, physical exercise, aerobic exercise, all of these things that can make that process easier, smoother, and less of a shock to the system, perhaps. I am a man. I probably will not be going through menopause. I imagine the change in testosterone will decrease, and that will be changed. But that idea is like, this is inevitable, and I can work with this, and I can manage this. I'd just be curious to know, like, what does that sort of sound like? The goal is not to delay. How do you, I guess, sort of view all of these inevitabilities? Because there's so much stuff that changes. There's new research. There's new ideas. How are you kind of like taking this, and what will you be doing kind of moving forward, in your practice with all this?
There is a group that you've probably, actually, I think I saw them at your last conference, that their work is using anti-Mullerian hormone to revitalize ovaries and to stop menopause. That's fine, actually. I think it's worth doing, but that is not my approach. To your point, I don't want to be fertile forever. I do not want to live in a state where my identity is defined by whether or not I can have children. That being said, once the ovaries stop, they're at this point, because of modern medicine, workplace safety, we have another 40 or 50 years to live. We cannot just feed off of the storehouses that we have accumulated in our first 40 years. So how can we pivot our mindsets to know that in the next 40 years, we can harness the wisdom of our age? We need to do to support that physically, emotionally, societally. I made up a word that I call this transition the menopause, as an analogy to your adolescence, where we shift from hormonally being a child to an adult, and now we're switching from being a reproductive adult into the rest of our lives. It's a biopsychosocial, hormonal, physical transition, and to get in front of it and optimize it, we need to increase our literacy. We need to build a lifestyle. We need to make our hormone replacement decision. That's what women need to do.
Dr. Wright, I think that is a perfect way to book in this conversation. So thank you so much for your time. Could you